Good evening, good afternoon, and good morning to each one of you. So, very warm welcome to our seventh session on capnography. So, seventh session of our biomedical engineering training course for critical care area products, and the session name is capnography. So, my name is Tarun Gupta. I will lead this session today. So, we will discuss about the clinical and no, I will cover the general troubleshooting related to the EtCO2 monitoring in this session. And at last, we'll have a question and answer session. So in this session, we will cover some topics related to the, some facts. We will discuss about some facts about the capnography. We will talk about the respiratory physiology. We will talk about the capnogram, and we will try to understand how the capnogram, how the EtCO2 graph looks like, and know how to read the capnogram. Then we will discuss about the importance of the EtCO2 monitoring, the measurement methods which are available, and the unique technologies of Nihon Kohden which are available for CO2 monitoring. So first, I start the topic. Let me, talk about some key facts. The capnography first is very important parameter for monitoring of the patient in the ICU, in the OR, in the ER room, in almost all care area of the hospital. And it's very interesting topic to the intensivists, anesthetists, ER doctors. Okay, so capnography. Capno means it's related to carbon dioxide. So capnography refers to the study and measurement of carbon dioxide in the exhaled gas. Okay, so it was first introduced by Karl Luft. So he was a German bioengineer. In 1943, he introduced the technology based on infrared spectroscopy. So he introduced the capnography. Capnography is mandatory. Monitoring capnography study is mandatory by American Society of Physiologists. In they say in 93% of all avoidable anesthesia-related incidents. So it is important to measure. The Indian Society of Anesthesiologists also makes it mandatory. So they are saying it's a desirable standard in its anesthesia monitoring standards recommended for India. So they have designated capnography as a very important parameter. And today, EtCO2 is measured in almost all the departments of the hospital. So let's, I will talk about some, abbreviations of PaCO2 like EtCO2. So what are some definitions are related to the capnography? Capnography means as a monitoring of partial pressure of CO2 concentration over the time. And there is a term called capnogram. Capnogram is related to CO2 waveform, which is plotted against time. So, and there are some terms like PaCO2. CP capital A is a partial pressure of carbon dioxide in the alveoli of the lungs. P small a stands for the partial pressure of carbon dioxide in the arterial blood. PtCO2 stands for the partial pressure of carbon dioxide at the end of the expiration. So the difference between the partial pressure of the arterial blood and the EtCO2 is called PAT, A minus CT. It's also called a CO2 gradient or CO2 difference. So these are some, keywords are used in the ICU, and I will also, cover. I will also use these keywords in the further slides. So let's start with the respiratory physiology. So you all know respiration. It's the intake of the oxygen and exhalation of the CO2. So it consists of two components: the inspiration and the expiration. So basically, to understand capnography, we also should know what's the oxygenation and ventilation. So oxygenation is basically related to the inspiratory phase. So it's related to the inspiration, and it refers to the amount of the oxygen which we are inhaling. Okay. There's a second term, which is the ventilation. So ventilation is related to the expiration, and it's related to the expiratory phase of the respiration cycle. So both oxygenation and the ventilation should be in the proper proportion to have a better quality of life for the patient in the hospital. So determination of oxygen status. So how the doctor, how the clinician in the hospital, they get to know about the oxygenation, how much patient is having the better oxygenation in the body. So there are the two ways. One is the invasive way. So invasive way, they take the blood sample from the patient, the arterial blood, and they measure the oxygen content, partial pressure of oxygen, which is dissolved in the blood plasma, and they measure in the ABG machines, blood gas analyzer. So in that they get to know what is the amount of the oxygen in the patient blood. So this is the invasive method. Now, non-invasive method is also there. So this is the pulse oximetry, which we discussed in our last session. So with the pulse oximetry with the infrared spectroscopy method, we are able to get to know how much amount of oxygen is there in the patient peripherals. Okay. Same way, there are some method of knowing the ventilation status of the patient. The ventilation, we can get to know, ventilation is related to how much CO2 content is there in the body, how much patient is exhaling out the CO2 on the body. Okay, it's the ventilation. So we can get to know about ventilation by invasive method. Okay, so from the blood gas, same on the blood sample which we taken from the patient artery. So in the same blood gas analyzer machine, we can measure the PaCO2 value, partial pressure of carbon dioxide, which is dissolved in the blood plasma. Then there are some non-invasive methods for measuring the EtCO2. So this is the PtCO2, it's a EtCO2 method. So when the patient is exhaling out the gas, so we can measure the non-invasive ventilation status of the patient. Can get to know. Now, the respiration of the patient are of two types: the external respiration and second, the internal respiration. External respiration is involved, exchange of gases from the atmosphere to the lungs, between the atmosphere and the lungs. The internal respiration is the exchange of gases in the blood cells. Okay, so we external respiration involves inhalation of oxygen and the exhalation of the CO2 from the lungs. Internal respiration, it involves oxygenation of the cellular, at the cell level. Every our part of the our tissues or cells, they need the oxygen. Okay, so for for the better cellular metabolism, so they need oxygen and glucose. So for the uh, formation of ATP, adenosine triphosphate, which is the energy packets. So when glucose is burned, so EtCO2 is the EtCO2 is produced and some water H2O is produced. So EtCO2 basically is a byproduct of the internal respiration, and by the blood circulation, the arterial venous blood circulation, we that EtCO2 is that CO2 content which is produced in the internal respiration is moved out of the body, and EtCO2, with the EtCO2 we get to know how much EtCO2, how much CO2 is exhaled out of the body. Okay, normal value of CO2 is around 35 mmHg. So with the EtCO2 value we get to know how good is the external respiration is happening and how good is the internal respiration is happening. Now, in the EtCO2 monitoring, we are monitoring the capnogram. So capnogram is the basically it reflects the PaCO2 waveform. Okay, so this is the cycle of the EtCO2 exhaled with respect to the time. Okay, and it involves the inspiration and the expiration phase of the respiration. So let's understand how the capnogram is formed. So see, for example, just take the here we have an alveoli. Okay, so when rise point of capnogram is formed, the beginning of expiration. So this is EtCO2 waveform. Okay, so this is at this point EtCO2 is at the zero level, 0 mmHg. Here, there is some value of the EtCO2. So when expiration starts, this is the beginning phase. The blue curve here is the beginning of the expiration. So when expiration starts, the alveoli, which is totally inflated with the gas, it starts deflating. Okay. So when it starts deflating, some you know uh, gas is expired from our airways also, window nostrils also starts exhaling. And we have a sensor over the nasal, or we can take the sampling for sample 2. We have sensors which measure the EtCO2. Okay, so when expiration starts, so this curve, the capnogram starts rising up. Okay, so this is the beginning phase of the expiration, and when we are exhaling, when we are exhaling the gas, the plateau is formed. Okay, so this declares the how much CO2 is there in the exhaled sample. Okay, so this is called alveolar plateau, and at this level we get to know how much CO2 is there in the patient. Patient how much is exhaled from the patient body. Okay, and at this time alveoli are totally deflated. So when EtCO2, and the end phase of this cycle of this, capnogram here, it is called as end tidal of the capnogram, end tidal of the expiration. So here at this time, alveoli are totally deflated, and we measure the EtCO2 at this point. And from this point, our inspiration phase starts. Okay, so there are the 5 phases of the capnogram. First is the beginning phase of the expiration. Then beginning of the CO2 exhalation in alveoli, we call it alveolar plateau. Then with the ended CO2, there is a point where we measure the CO2, and this is the inspiration phase of the alveoli. Okay, so here we again take the inhale the gas, and alveoli are again inflated. So this is the our respiration cycle, which is which we can see on the capnogram. So in ideal situation, in the normal body, where when our respiration, circulation, and the ventilation are all normal, so at that time, for PaCO2, whatever blood blood partial pressure of CO2 which we have in our arterial blood, the same blood is same amount of the oxygen CO2 is exhaled from the body. So in the normal situation, PaCO2 value, which is which we are measuring from the EBG, is equivalent to the EtCO2 value. Okay, but when there is some problem with the patient lungs, some pulmonary circulation issues there, or some problem with the lungs, so at that time, EtCO2 value differs to the PaCO2 value. And most of the time in the ICU, in the OT, so doctor they do measure the continuous CO2 on them with the EtCO2, and in between they do the EBG test also to check whether the patient pulmonary functions are correct or not. So during the normal ventilation, if the exhalation of EtCO2 is good, means the ventilation from the lungs is good and the pulmonary blood flow is good. At that time, EtCO2 values are equal. Okay, this is the blood circulation, and here we are having the lungs. Okay, so whatever partial CO2 content we have in your blood is diffused back to the alveoli and it is exhaled from the lungs. So both the EtCO2 value and the PaCO2 value are similar. But there are some conditions, in the with the patients in the ICU or in OT, where EtCO2 value is not equivalent to the PaCO2 value. Okay, there is some differences there. Okay, so when PaCO2 value, like, there are two types of conditions. Okay, one condition can be related to the ventilation, or second can be related to the pulmonary blood flow condition. So if it is related to the ventilation, means there is some problem with the lungs. Uh, like if the patient is in the trachea, they have a tracheal stenosis, asthma, or hyperventilation is there. So at that time, oxygen EtCO2, which is there in the your blood, is not able to diffuse back to the lungs, and patient is not getting is not able to exhale proper CO2. So EtCO2 value at a time will be less than the PaCO2 value. Okay. The other condition, when the ventilation is good, means lungs are good, there is no problem with the lungs, but the circulation in the body is not perfect. So in that condition, or EtCO2 value is very less, and we are having the high PaCO2 value. Okay, it happens because of the low blood pressure, asystole, pulmonary embolism, or at this time, pulmonary blood flow is reduced. So there are some conditions, in uh, the ICU, in the OT, so where the doctor do measure the EtCO2 value, and they do correlate with the EBG value of the blood gas analyzer. Now, what's the importance of monitoring the EtCO2? The American Society of Anesthesiologists, I show you in the first slide that they have made it mandatory to measure the EtCO2, okay, in all the types of patients who are getting the sedation. So those who are in the OT or the ICU, if they are getting the sedation, if they are getting the if they are using making the patient sedate, so it is mandatory to measure the EtCO2 of those patients. Okay, and the very commonly used EtCO2 is in the OT. So when the patient is on the is totally sedated, patient is on the mechanical ventilation on the workstation. So patient is not inhaling or exhaling on his own. He is on the ventilator. So it's very important to measure EtCO2 of those patients, those intubated patients. Okay, so with the EtCO2, we'll get to know if there is a misintubation has happened, or if there is a kink in the hose, or disconnection of the ventilation, or some air leakage is there, or there is a rebreathing of the CO2. So they are very, EtCO2 is having very important, you know, uh, it's a very important parameter in the OT. Okay, so it can relate to many conditions. It can happen, it can be there in OT. So one of the conditions is the apnea. That if in case of disconnection is there, patient is not the ventilator, there is a disconnection of the ET tube and the ventilator tube. Patient is not getting the enough ventilation. Okay, or there is a kink in the ET tube. So what will happen? It will give there will be no CO2 monitoring, and monitor will give the alarm of apnea. Okay. There are other parameters like ECG and EtCO2 that will be there, that will be shown on the monitoring scale. Okay, but the EtCO2 is the first parameter which will tell you that apnea has happened, and you can see from this illustration that EtCO2 is the first parameter whenever there is a oxygen supply has been stopped to the patient, or when there is some tinting is there of ET tube or disconnection of the ventilator, and the oxygen supply has been stopped to the patient. So EtCO2 is the first parameter. Okay, so it will just before the patient death, like say let's say illustration, just before 5 minutes of the patient death, EtCO2 will tell you that there is no apnea alarm is there and patient is not getting enough oxygen. The pulse oximeter will tell you, later on, it will be the alarm, and ECG at last when the patient is going to have a AC score of patient is having event. So you can see from this graph, so whenever there is a ventilation problem is there or some respiratory problem occurs, okay, EtCO2 will first give you the alarm, apnea alarm will come, okay, then it starts giving the alarm. After a few time, after a few minutes, then you will get the SPO2 alarm. So EtCO2 is very important, okay, to detect any respiratory problems there. Okay. Also, EtCO2 has been mandated, recommended by the ACLS. So this is the advanced, for this situation monitoring, like when we are in the when we are doing the resuscitation of the patient from the sudden cardiac arrest. So some international bodies like EtCO2, American Heart Association, European Resuscitation Council, so they do have recommended the monitoring of EtCO2 in the during the resuscitation. Why EtCO2 is important? So they have defined four factors where EtCO2 is very important. First, to confirm the tracheal tube position. In case during cardiac arrest of the post-cardiac you are intubating the patient. So to confirm the tracheal tube position, you should make EtCO2. So they say second is to ensure the quality of CPR. So at the time of cardiac arrest, so we are situating the patient, which we discussed in the first session, that when we are instituting the patient, we are giving the CPR to the patient to ensure whether we are giving the good quality of CPR or not. So EtCO2 will will help you in knowing the quality of CPR. In case the patient is revived from the CPR or from the defibrillation, so in those conditions, that condition is called return of spontaneous circulation. So to identify return of spontaneous circulation, EtCO2 will help you. And at last, when you are giving the ventilation to the patient with the manual with the ambu bag, so to prevent the hyperventilation or hyperventilation of the patient, so EtCO2 will help you. So here we are, in this slide, I'm going to show how the EtCO2 is important in the tracheal tube positioning to know the value of the ET2 which we have, insert in the patient trachea is insert in the right position or not. So see, when just before the intubation, EtCO2 value will be at the zero level. Okay, to show the zero energy. When the intubation happens and when the intubation is correct, so we start getting some capnogram. So with this, capnogram on the screen, doctor will get to know that intubation has happened perfectly. Okay. Now to ensure the quality of CPR, when the patient is in the sudden cardiac arrest, so patient is also not exhaling the gas. Okay, so we can measure the when we are giving the compression of the with the when we are giving the compression to the patient when we are giving the CPR. If we are giving the weak compression, the value of the EtCO2 will be less than the 10 mmHg. Okay, and when we are giving the strong compression and when we are giving the good compression, then we will have the value of EtCO2 in the range of 10 to 20 mmHg. Okay, so EtCO2 will help you help the resuscitator or use the person who is resuscitating the patient, okay, to know the value of whether he is giving the good CPR to the patient or not. Okay, so efficiency of CPR, the person will get to know. Now, in case the patient has revived from the CPR, okay, or we are giving the shock to the patient has returned to the spontaneous circulation. So when the circulation, the patient's own circulation, spontaneous circulation comes back, we will get the EtCO2 value will rise up and it will come in the range of 35 to 40 range. Okay, so you can see the events. This is the CPR. We are giving the CPR to the patient. Now the patient own circulation has come. The patient is revived from the sudden cardiac arrest. So we'll get the amplitude of the capnogram will increase and we will get the value of EtCO2 at around 35 to 40 mg. Okay, so EtCO2 helps you in this condition. Now, EtCO2 will also help you in knowing there is a special, you can say, it's very important for measuring the EtCO2 in brain surgery. Okay. Uh, in brain surgeries, when they are open the brain, so it's very important for them to maintain the cerebrospinal fluid content of ICP, cerebrospinal fluid content also in the brain. Okay, so if the CO2 content, if the reduced, if the PaCO2 is reduced, with the reduced PaCO2, vasoconstriction can happen. Okay, vasoconstriction means the arteries which are supplying the blood to the oxygenated blood to the brain tissues, those get constricted. Okay, so because of those vessel constriction, cerebral ischemia may happen. Okay, cerebral ischemia is related to the ischemia is related to the hypoxia of the tissues. Okay, so vasoconstriction can lead to the cerebral tissue hypoxia. Okay, because of vasoconstriction. If there is an increase in the PaCO2 value, then vasodilation can happen. Okay, so with the increase of vasodilation, it means diameter of the vessel is increased, so it can lead to the intracranial hypertension. Means the blood will rush to the cerebral tissue, and they are doing the brain surgery. There will be a lot of loss of the blood. Okay, so it's very important to maintain the CO2 level of the patient in during the brain surgeries. I will show you one example. So this is example of this, surgery, epilepsy surgery. So this is a musician. You can see he had some problem with it. To he's a guitar player basically. Okay, so he had a problem. He was not able to move his hand. So he was not able to move his fingers, okay, to play the guitar. He has some epileptic problem. Okay, so during epilepsy surgeries, the most of the surgeries they are done when the patient is awake. Okay, so they recalibrate some nervous tissue of the brain. Okay, in the during this type of surgery. So it's very important to measure CO2, because if the CO2 content, the PaCO2 value is increased in the blood, so there will be drop in the pH value. Okay, so there will be the acidosis, the carbonic acid will increase in the blood. So because of acidosis, vasodilation will happen. If vasodilation happens, means the vessel size of vessels will increase, and the blood will rush to the brain, and there will be a lot of loss in the brain, and the intracranial pressure, which is also called ICP, will increase. Okay, and the surgeon who is doing the brain surgery will have a lot of problem in doing the surgery. It's very critical situation, so it's very important to measure the EtCO2 during these type of surgeries. And generally it's very important to measure EtCO2 when all the conditions, like when the patient is sedated, when the patient is intubated, during the CPR. Okay, and to know the apnea of the patient, right? So apnea stands for no respiration for some time. Okay, now in case apnea, it can happen when we are sedating the patient first, or it can happen when there is a disconnection in the ventilation. So to know whether the patient in apnea or not, so it is to will help you. Um, uh, Now we will discuss some measurement methods. Okay, how the EtCO2, how the CO2 is measured. There are different techniques to measure the CO2. First, this is invasive method. It's a arterial blood gas and gas, ABG. It stands for the arterial blood gases. And the machine which we use is called blood gas analyzer. Here we are taking the blood sample from arterial blood, and we are measuring the CO2 in the machine. Okay. The second is the transcutaneous CO2 method, where we are touching the sensors over the patient body. Mostly transcutaneous CO2 is used in the neonatal cases. Then we are having the EtCO2 method, which is a non-invasive method. So we can measure the EtCO2 via the mainstream sensor, which is attached over the patient. We'll talk in the next slides. And there is side stream method. So there are different methods for CO2 monitoring, right? For knowing how much CO2 content is there in the patient arterial blood. So every technology has some merit and demerit. EtCO2, which is mainstream EtCO2, its merit is it's non-invasive, it will go continuous, it's convenient, and there is no lag time. We are directly measuring from the patient mainstream, from the patient mouth side. Demerit is there's a bulky sensor. We can use intubated patient only. Okay, we discuss more on the mainstream and side stream in the next two slides. Side stream is also non-invasive. It's continuous, but there's no time delay is there. The lifetime is there in the capnogram. We don't get the better capnogram in the side stream method. So lifetime is there, and it takes a long time in warm up. So it takes we get some delay in the EtCO2 reading. Then we are having the articulate analyzer articulate sampling method, which is the PSO2 method. It is accurate method, but it's expensive because it takes because some reagents are involved in the different machines. It's a costly method. It takes the time for testing and it's not continuous. We need to take the blood and we need to go to the laboratory and measure the CO2 there. Then we are having the TCPO2. It's continuous. We don't need any sampling, but it's expensive and there is a risk of flame burn. Okay. So in the patient monitoring, we are mostly using the two methods of CO2 monitoring, on the mainstream method and the side stream method. In the mainstream method, the sensor is on the patient mouth side. Okay. And the side stream, the sensor is on the monitor side. So away from the patient. Okay, so it's called side stream. So here we are having some comparison between the mainstream and the side stream method. Mainstream method, the response time is fast. Is very fast because the sensor is on the patient side, so it's very fast. Side stream, the sample is taken from the patient. Patient is daily. This is ventilator tube. Patient is daily. There is sampling to the dash here. The sample of the exhaled gas. It goes from the sampling tube. It goes to the sensor, which is there on the monitor side. Okay. So it takes some time. Okay. That is why the response time is so slow. Okay. The waveform, the capnogram which we get from the mainstream sensor is the accurate. Okay, because the sensor we getting processing of the sensor is fast because the sensor is there and we get a better capnogram on the screen. Here in the side stream method, there is some distortion happens, some lag time is there, and you don't get better capnogram. Long time measurement is easy because there is no sensor is there. Okay, so it can be used for a long time. The side stream method, when we are exhaling gases, so we exhale, moisture also. So in the sampling tube, moisture gas condense and the PTCO2, the accuracy is hampered. So it's not used for the long time measurement. We need to frequently change the sampling tube BOT. Then the sensor size, in the mainstream, earlier the mainstream sensor, conventional mainstream sensor, those were very heavy because those were very large and heavy. Okay, this one is a mainstream sensor. So, but the side stream sensor size is not considered. It's not a factor of anything. So it's a small and lightweight. In the mainstream sensor, the sensor size was large and heavy. It is recommended method, but because of this sensor size, in the generally in the OT, in the the trend of it is CO2 monitoring. So people are not using the mainstream method just because of the its heavy weight. If the weight is more, it will make the PT2 king, or it is having a filter inside, so it makes the 82 king, and it's heavy. It's because of its weight, it can make the 82 king, and once it is fall down, it's very fragile. So if it falls down on the floor, it gets break. So because of this limitation, uh, hospitals are using mostly the side stream method. Okay, so this was a limitation in the conventional medicine method. Earlier, mainstream sensor, they have application we can use on intubated patient only, whereas side stream they can be used on both intubated and the non-intubated patient. I hope you understand intubated. Intubated patient are those who are having the 82 inside. Okay, so once like I showed you 82, so when the patient is in the OT, they insert the 82 to make the ventilation to the patient. So mainstream can only be used on the intubated patient, and but side stream we can use on both intubated and on the non-intubated patient, those who are not having the ET2. The mainstream earlier was having the last dead space. Okay, so we'll discuss about the dead space in the later slides. Now, see the how the main ET2 is measured in the mainstream method. This is the patient side, and this is the ventilator side. The CO2 sensor is attached over here. When patient exhales the gases, EtCO2 is measured by the sensor here, and we get the capnogram over the monitor screen. Okay, this is how the mainstream works, and this was the conventional type of EtCO2 sensor. See the weight and the large size of the sensor. It is having earlier the EtCO2 was having the sensor. We are having the heater inside. When we are exhaling the gas, you can see the moisture here. When we are exhaling the gas, that exhale, that moisture can come over the this part of the adapter, and it can make the EtCO2 reading inaccurate and inefficient. So we need to have a heater here to make those water vapor evaporate. So that is why the EtCO2 sensor was very heavy. So some type of EtCO2 sensor was having some heater or some motor type of thing. So that's why it's a very large size, and they need to keep the pillows and towels to maintain its position, so that ET2 doesn't get things or come out of the patient body. So it was the limitation of side mainstream sensor. Now in the side stream method, you can see the CO2 gas is exhaled from the patient. It goes, there is a sampling tube we attach here on the adapter side. So some of the EtCO2 goes back to the ventilator, and some EtCO2 sample goes to the machine, and we get the capnogram on the monitor side. Okay, here the CO2 sensor is on the monitor side. Okay, so that is why we call it as side stream method. Okay, this we can use. You can see the response time. It's taking the CO2 sample is going from the ventilator tube side to the monitor side. It is taking some time. This response time is slow. Also, the waveform which we get on the monitor screen is distorted, so lifetime is there. Long time measurement is difficult because in this sampling tube, you can see this is an example of sampling tube. The water get condensed, and accuracy of the EtCO2 is not maintained for the long time. So we need to change this sampling tube in between. It has, it can be use on, it's a small, the smaller light means there is no sensor compared to, it's very lightweight. So sensor is very, sensor is very small and light, and we can use them both into the non-identification. So there are some, differences between the conventional mainstream sensor and the side stream method. Now, the Nihon Kohden, we have developed some CAP1 technologies, we say. So we have developed some, unique technologies in our monitors. So we have developed, you know, we have tried to overcome all those, disadvantages of mainstream, conventional mainstream. We have tried to overcome those. Let's take the first disadvantage of conventional mainstream, which is the sensor size, large and heavy. So to overcome this, what we did, this is adapter of the EtCO2 sensor. What we did here, EtCO2 sensor is attached. So we have attached one anti-fogging element here. So then you can see, when it is attached to the patient is exhaling the gas, you can see some fog over here. But here we are having the anti-fogging membrane, so there will be no fog on this side. And this is why we are able to reduce the size of the EtCO2 sensor. In our EtCO2 sensor we don't have a heater, so instead of heater we have anti-fogging membrane in the adapter side, so we have reduced the weight of the EtCO2 sensor. So how the anti-fogging membrane works? Normally, in the mainstream sensor, the conventional mainstream sensor, the moisture of the patient, it tends to condense over the membrane side, and it condenses in the like a water vapor, okay, water droplet. So the infrared light, which is coming from the transmitter, it gets deflected or reflected. Okay, so there is a mathematical measurement. In our method, anti-fogging membrane, what it does, so it is making the water droplet to make a water layer. Okay, so the water layer is formed over this membrane. Okay, and there is no reflection or the reflection of the infrared light. So it makes the EtCO2 monitoring accurate for a long time without the need of any heater. Okay, here heater is required to make these water droplets evaporate. Okay, so with the application of anti-fogging membrane in the adapter side, we have reduced the size of our EtCO2 sensor. Okay, so you can see conventional EtCO2 sensor, they are too heavy, the size of this sensor. Our sensor size is only 4 gram weight. Okay, and you can see here, you can attach to the patient. This is a neonatal patient. Here you can attach directly to the patient without use of any towels or pillows. Okay, it is so lightweight. Okay, it will not make the ET2K or drag out of the patient back here. So with the anti-fogging membrane, we have overcome this disadvantage. The next disadvantage of conventional mainstream was it can be used only on intubated patient. Okay. So we had developed all EtCO2 sensors. So we call it CAP1. One CAP stands for capnography. One stands for oral nasal expiration. Okay. So we had developed this type of adapter, which can be used on the non-tubated patient. Non-tubated patient are those who don't have any attitude. Also, we have developed the oxygen mask. Okay, so when the patient is sedated or in the ER room, when they need to give the oxygen to the patient, when they are giving the oxygen to the patient, they can monitor the EtCO2 also. Okay, so you can see with this we can use on non-tubated patient also, and our cap or mask. capillary mask, we can the design of a mask is like it can be it can save the oxygen supply of the in the hospital also. With the 2 liter of flow of oxygen, we can maintain 40% of the FiO2. And for EtCO2 sensor, we can use on both integrated and non-integrated patient. So we have overcome this disadvantage also. One more disadvantage was the amount of dead space. Earlier mainstream sensor was having the large dead space. Okay, but the side stream method they are having small dead space. Now to overcome what is first we need to understand what is dead space. Respiration. I just covered this slide. Inhalation, exhalation. But actual it is happening. Actual respiration is happening in the alveoli. Okay. So what is dead space then? So dead space, if you see, dead space is all those airways, bronchi, trachea, those things, those part of the lungs, anatomical part of the body, where the gas exchange is not happening. Okay, this is all dead space. Actual gas exchange happens in our alveoli. Okay, so when So this is the anatomical dead space of the patient where the gas exchange is not happening. Okay. Now take the example of patient is on ventilator. Okay. Usually our human body tidal volume is inspiration and exhalation of the gases. Okay, the volume of the gas. So it's per kg. In the calculation, doctors take 6 to 10 ml per kg as per the patient condition. They calculate the tidal volume to set on the ventilator side. The human body, the anatomically, okay, the dead space is our dead space is about 2.2 ml per kg. Okay, this dead space is about 2.2 ml per kg. Okay, now let's take the example of 60 kg adult patient. So the 60 kg of adult patient, let's say if we take the 10 ml per kg, the tidal volume will be at around the 600 ml. Okay. Same way, if we take the 2.2 ml per kg and we multiply with the 60 kg, so the adult patient with having 60 kg weight will have the dead space of 122 ml. Okay. The actual gas exchange which is happening in the alveoli is 460 ml. You can see doctor has set in the ventilator they have set the tidal volume of 600 ml, but the actual gas exchange is only 468 ml. Okay. In the case of infant, in the case of neonate, the body weight is very small. Okay, very small weight. So anatomical weight wise and size wise, the patient is very small. So infant, let's take example of 1.5 kg. The tidal volume, if we take 10 ml per kg calculation, so doctor will set about 15 ml of tidal volume in the vertical size. 2.2 into 1.5 kg, we get 3.3 ml. The actual gas exchange which is happening in the infant body is about 11.7 ml. Okay. Now, if we attach a adapter, okay, the patient is on ventilator. If we attach an adapter over there, okay, let's say we are attaching the conventional adapter, which is having the 4 ml dead space. Dead space is no gas exchange. Okay. If we attach the 4 ml dead space, actual gas exchange will reduce to 7.7 ml from 11.7 ml. Okay, so there is a percentage wise, it is very large. So 34% less gas exchange is happening. Okay, we have developed a very small adapter which is having the dead space of only 0.5 ml. So with this, we can reduce the dead space of up to 11.2 ml only. Okay, and it is just 4.3% less. Okay, So when the neonatologist or intensivists in the NICU, they are calculating the tidal volume. They do ask about the dead space of the sampling tube. They do ask about the dead space of the ventilator tube or adapters. Okay, so that they can calculate the tidal volume of the patient. So it is very important factor or very important parameter for a doctor to adjust the tidal volume on the ventilator side. So earlier, I told you the mainstream sensor was having the large dead space. Okay, so they are they are not used in the mostly in the universities and ICUs. So that space is just 0.5 ml, which is smallest in the competition. And so with this technologies, with this all those which I told you, that sensor size we have reduced. So in our technologies, Kappa mainstream technologies, so we are able to overcome all the disadvantages which are there in the conventional mainstream technology. Okay. So Nihon Kappa technologies, mainstream technologies, the response time is fast. We'll get a better capnogram, accurate capnogram, and it's easy for the long time measurement. Force size is just 4 gram weight, small and lightest in the world. We can use on both intubated and non-intubated patients, and the dead space I just told you is just very small. Okay, we can use on the just 0.5 ml for the patient. So this was about question from Devanjan. Can you please explain EtCO2, PaCO2, and PaCO2? So, see, Devanjan, the difference between the PtCO2, ET, P first stands for the partial pressure, ET stands for the end-tidal, okay, and capital A here, PaCO2, PA stands for your alveoli, okay, small a stands for arterial, okay. So PtCO2, it determines how much CO2 partial pressure of CO2 is there in the exhaled gas in that and in the exhaled gas. P capital A CO2 stands for the partial pressure of the CO2 in the alveoli of the lungs. P small a CO2, it stands for the partial pressure of CO2 in the arterial blood. Okay. So this is the difference between the PtCO2, PaCO2, and PaCO2. Next question is from Mr. Sajjal. Is the Cap1 mainstream comparable to Medtronic microstream technology? See, Sajjal, Medtronics make microstream. See, microstream technology is similar to the side stream technology. In the in the side stream, we are taking the sample of the gas. So in conventional side stream, we are taking the around 200 ml of the gas we are taking. Okay, but in the microstream, they have developed some technology. The sample required for measuring the CO2 is less. They just require the 50 ml of the sample, but it is it is similar to the side stream technology. So whatever this sort of difference between the mainstream and microstream I told you, side stream I told you. So microstream does have the same limitation as for side stream method. Question from Vishal. How long we can use Cap1 sensor and what about the calibration? The Cap1 sensor we can use for the long time and there is no need of calibration. Okay, it is auto calibrated. So we can use it for the long time till the time we have an airway adapter in between and we have anti-fogging membrane in those adapters. So till the time there is no mucus or there is no dust particle over that it is anti-fogging membrane. So it is if it is transparent, it is clear, we can use it for the long time. Okay. Actually, it all depends on how well they have maintained the patient. Are they doing the ICU? Is the patient is in the ICU? Are they doing the proper suctioning or not? Okay, it all depends on the how well maintained they are with the patient. Okay, or how well they are doing the suctioning of the how often they are doing the suctioning of the patient. Question from Mr. Hetu. Can we clean the adapter and reuse or it is one-time use? See, these adapters, they are this is a disposable part and this is a one-time use. And it cannot be, we as a company, we don't recommend to clean these adapters. And whenever there is, there is a chances of, infection. If you are using the second patient, so there is a chance of infection. So we don't recommend to reuse on the second patient. Okay, so it is disposable. Question from Tisha, where sensor is placed in case of side stream capnography? See, in the case of side stream capnography, we are taking the sample. Okay, so the sensor is on the monitor side. Okay, so sensor is in the monitor side. Okay, and we are just taking the sample from the 82 or 22 to the monitor side. The sensor is placed on the monitor side. Question from Mr. Shem Muticho. Can we have a slide repeat on the internal respiration? See, internal respiration is happening inside the body. Okay, it's between your blood cells. Okay, it's between the blood and the tissues and the cells of the body. Okay, so each part of the body, each part of our cells, blood cells, they do require the oxygen to take the glucose level. Okay, glucose. Uh, So when we are inhaling the gas circulates through the our blood. It goes to the each part of the body, and the cells, the tissues, they take that take those oxygen, and they the byproduct, after breaking the burning the glucose, they produce the CO2. The CO2 goes back to the bloodstream, and from the venous return, it goes to the heart, and from heart to the it goes back to from the lungs, it goes back to the it is exhaled from the body. Okay, so internal respiration is between the blood and the blood cells, and the between the tissues of the body. Question from Mr. Manu: can we derive PaCO2 value from PaCO2 or from EtCO2? See, Manu, in the normal, ideal, normal ventilation, PaCO2 value is equivalent to the EtCO2 value. Okay, so it's similar to the EtCO2 value. EtCO2 is just a non-invasive method of knowing that value. Okay, we cannot drive those values because in some conditions, like in tracheal stenosis or the bronchitis or the sleep patient, so the PaCO2 value will be higher than the EtCO2 value. Okay, so we cannot drive the value. It depends on the patient condition, how the patient is. It's a question from Mr. Amir. Sorry, what you mean with the term dead space? The dead space is the, like if you take the example of your body, okay, so your nose, your trachea, your pharynx, your bronchi, these are all dead space where the gas exchange is not happening. Okay, gas exchange is happening only in alveoli. Okay, so that is the main part of the lungs. All the airways of the body, and if we attach the ventilator tube, these are all termed as dead space. Dead space is basically where the gas exchange is not happening. Okay. Yeah. So thank you guys. Thank you for joining this session. Okay. If you have any question, you can mail us. Okay. So next session is on 29th of January. So it will be on the medical supplies and accessories. So uh, wait till next week. Okay. Thank you. Thank you for joining to this session.